Hello, everyone. My name is Dr. Montserrat Paez Espinoza. I am a third-year family medicine resident at Memorial Health, Southwest Oklahoma in Lawton. I am here to tell you about my quality improvement project, which was improving breast cancer screening rates for uninsured patients in a residency clinic. So, breast cancer remains one of the leading causes of morbidity and mortality for women in the United States, with a 1 in 8 lifetime risk that a U.S. woman will develop breast cancer. This incidence has continued to climb over the ages, but deaths related to breast cancer have actually continued to decline. Now there's only a 1 in 43 chance that a woman will die from breast cancer. And this is thought to be secondary to improved awareness, improved access to screening, and better access to treatments. We know that screening every 2 years per USPSTF guidelines can actually save 7 lives out of 1,000 women screened. And that's a significant number. Unfortunately, as a Spanish speaking provider in Lawton, a lot of the patients that I have that are uninsured are also undocumented and do not have a social security number. What we found when I was caring for these patients was that the main program we had in place to help provide services to uninsured patients was Take Charge through the state. And after several rejections, I realized that the social security number was actually a requirement for both application and approval through this program. And so a lot of my patients didn't have that and weren't able to get their services through the system. And through a contact in the health department here locally, I was actually able to learn about Oklahoma Project Women, which is a non-for-profit organization that does not have that requirement. And I was able to bridge the gap for my patients in that way. But in doing so, I learned that a lot of my co-residents, my faculty, were not familiar with this process. And so I wanted to particularly target this very vulnerable population. So I wanted to achieve at least a 50% increase in the percentage of self-pay female patients ages 52 to 74 who received their screening mammograms post-intervention. And so the intervention was the creation and implementation of this algorithm that helped show the resident physicians in our clinic where to funnel these patients. So either Take Charge or Project Women determined by their eligibility criteria. What we found was that after the implementation of this algorithm at the end of February, starting March 1st, there was actually a 10.5% increase in self-pay compliance with screening mammograms and a 6.5% increase in screening compliance in our insured patients. This didn't reach the 50% increase goal that we had for our study. However, we think that the impact was limited due to certain limitations in our study. The first being data collection. The original target age range was 40 to 74 per USPSTF guidelines, but unfortunately, our clinic system uses CMS designated age parameters in the capturing and retrieval of this data through our electronic health record. And so there were 12 years that were unaccounted for. So the 40 to 52 age range could not be captured. So the parameters of our study actually had to be adjusted. Additionally, there was some overlap between the patients that were seen in the pre-intervention and post-intervention period. So if those patients were seen before and after March 1st, they were counted twice, and this wasn't reflected in the data analysis. The last real barrier to or limitation of the study is the duration. I think that once we start stacking barriers to patients, a lot of our uninsured patients have additional limitations of poor access to transportation, language barriers, and ability to take time off work. And when you put a time constraint of 2 months to allow them to get their mammograms completed, it just wasn't enough time for them to coordinate all the things that they needed to get their care. So I think this study is a good launching point for further studies with a longer period of duration, perhaps more specific data analysis that is able to separate out the patients so that they're not counted twice in the pre and post intervention. But ultimately, I think that in creating this referral algorithm that can long outlast the study, we'll be able to help care for these patients in a truly holistic way, understanding that they are a product not just of their inherent risk factors, but also of the environment that they live in and the circumstances that they live in. Thank